Hi everyone, welcome to Research MD. This is Dr. Pramel. I work as a Program Director, Internal Medicine Residency Program, Chief Medical Officer. Today we're going to continue our lectures to teach you about in-service training examination, hot topics. And this is what people usually miss in the in-service training exam. Again, one more reminder, if you do score really well in the in-service training exam, your life as an internal medicine resident is going to be much better. Everybody in the program will loves you. You may be able to get your favorite fellowship. So pay attention to what we're talking about today, okay? So our topic is nephrology again, causes of hypophosphatemia. Okay, now how do we approach it? First, we'll give you a case scenario and then we will look at the causes. We got a 28-year-old woman came with a leg weakness, nausea, and she was taking intravenous ferric carboxymaltose for severe iron deficiency anemia, and then the vital signs were pretty stable, and they looked at the lab, sodium 136, and the phosphorus is 1.2, right? That's the main key. So which of the following is most likely the cause of hypophosphatemia? You got ferric carboxymaltose, low phosphorus diet, metabolic acidosis, and prednisone, okay? So the answer in this is ferric carboxymaltose for iron supplement. For this patient, it increases our FGF23 level, which will decrease the phosphate reabsorption in the kidneys and decrease calcitrol production. Okay, that's the mechanism. Now, let's look at, when you look at the causes of hypophosphatemia, let's put it into 4 different branches. The first one is increased cellular uptake of phosphate, and then reduced intestinal phosphate absorption, and then you have increased renal excretion, and then you have medication associated with the hypophosphatemia. Okay, now let's look at the first one, increased intracellular uptake of phosphate. You got refeeding syndrome, DKA, increased insulin secretion, acute respiratory alkalosis, and hungry bone syndrome. Okay, and then you have reduced intestinal phosphate absorption. What you have is like vitamin D deficiency, diarrhea you have in there, malabsorption is there, and then the next big category is like increased renal secretion. Okay, that's it. You got elevated phosphatidylcholine hormones, like we're talking about again, parathyroid hormone, very important, hyperparathyroidism. I think everybody get that. And then you got diuretic, you got Fanon Syndrome, and ferric carboxymaltose, which is the answer to our case, the ferric carboxymaltose, okay? And the medications, you have to think about antacid, calcium, phosphate binders, diuretic, and you can add tyrosine kinase inhibitors also in there, okay? And now, let's look at like each one kind of a little bit more specific so we understand the situation better. Now we go into the first category, increase the intracellular uptake of phosphate. Now, so each one we will look at. One, refeeding syndrome. There is a rapidly shifting of this phosphate into the cells during when you try to feed again, okay? And then also in DKA, in the DKA, like what happens is you got increased urinary phosphate excretion from, you got, again, everybody know there's osmotic diuresis and shift of phosphate into the cell, okay? So osmotic diuresis in DKA because all this glucose, and then increased urinary phosphate excretion from shift of phosphate into the cells, because what happens is like what happens when you give the, how do you treat DKA? You give insulin. Now, there's increased insulin secretion, insulin treatment, again similar, shifting into the phosphate, and then you got acute respiratory alkalosis, which drive phosphate into the cell because of what? Intracellular pH increased, okay? Then you got hungry bone syndrome, the rapid uptake of phosphate into the bones during the recovery phase after parathyroidectomy is the other one. And now let's look at the other big category, reduced intestinal phosphate absorption. Main thing, vitamin D deficiency. I think most people know that. It decreases serum calcium, increased PTH, increased renal phosphate excretion, hypophosphatemia, okay? Then chronic diarrhea, malabsorption syndrome, alcohol abuse. Don't forget it, alcohol abuse, okay? Now, the next big category, you got increased renal excretion. Now, causes elevated phosphatidylcholine hormones like parathyroid hormone, diuretic, Fanconi syndrome, renal tubular reabsorption is decreased, that's why the phosphate is going to go down. Now, this is when you talk about Fanon syndrome, always think about, type 2 renal tubular acidosis. Somebody can write a question kind of linking them together. Hypophosphatemia, Fanon syndrome, renal tubular acidosis. Some smart guy is going to write a question, remember that. And then you got tyrosine kinase inhibitors. They disrupt the FG23 signaling, lead to renal phosphate excretion, so phosphate goes down. And then we always talked so many times about ferric carboxy maltose, like iron supplement, increase FGF23, which decrease the phosphate reabsorption in the kidneys and decrease calcitrol production, okay? Now, the medications also you have to know. Antacid, calcium. What does it do? Calcium bind the phosphate in the gut, and the diuretic that can also decrease the levels, and again, tyrosine kinase inhibitors. Now, it's a big topic, but remember to go through this. Very good examination question. So many things, linked together. Thank you so much for watching. Please help us subscribe to our channel. So we wanted to make more and more in-service training examination a high value topic. Okay, thank you so much. God bless.